Hi, this is Peggy O'Connor, and this is a review of acute respiratory disorders in children.
So this is a review of the maturational differences between infants and small children and adults. They are obligatory nose breathers and diaphragmatic breathers. Their trachea and bronchioles are narrower and shorter. Their larynx is funnel-shaped. Their chest wall and intercostal muscles are too weak to actually lift the chest if their diaphragmatic breathing fails. Retractions are a result of increased work of breathing. Respiratory rates are normally higher, and the eustachian tube is shorter and more horizontal. So this is a concept map of the respiratory assessment. So you're going to be checking to see what the past medical history is of the child. Have they had frequent upper respiratory infections, sore throats? Have they been premature? Have there been other respiratory illnesses? Then asking family history. Is there significant chronic respiratory disorders in other family members? And then we're going to go over and we're going to assess what the present illness is. And we want to get a history from the mother. Onset and progression of the illness. Has there been a fever? How high has it been? What the respiratory symptoms are, if they've noticed any congestion, noisy breathing, presence of a cough, ear, nose, and sinus pain, pulling of the ear, poor feeding, or if there's been exposure to secondhand smoke. And the last part of the assessment is the physical exam. So the nurse wants to go in and assess interaction of the child with their environment. Look for respiratory mechanics. Is there any nasal flaring, retractions, or grunting? Then listen for any adventitious breath sounds. Do they hear stridor, wheezes, or crackles? We want to assess the hydration status by doing daily weights. Vital signs will give us the respiratory rate, and listening to the breath sounds will tell us about any adventitious breath sounds. Thank you. So this is just a summary of tonsillitis in general. Children generally outgrow it in their school age years, and so it is usually treated with antibiotics. But if they are not working and they have frequent tonsillitis, then surgery can be considered. So you want to watch out for postoperative bleeding, and the biggest sign for that would be swallowing frequently. And in order to prevent post-op bleeding, have them avoid swallowing sharp objects, and milk should be introduced on postoperative day 2. To promote a decrease in swelling, offer cool, soft foods, and bleeding is considered a medical emergency where the child should go to the nearest emergency room immediately for immediate surgery. So in summary for croup, we want to keep the airway open. We want to make sure that we are checking either ABGs or their pulse oximetry, and crying will aggravate airway obstructions, so we want to minimize crying. If the child suffers from stridor at rest, cyanosis, severe agitation or fatigue, or moderate to severe retractions, or they are not drinking, they need to go to the emergency department immediately. You want to perform a respiratory assessment, and your treatment is going to include racemic epi, dexamethasone, either IV or oral, and humidified oxygen if they are hospitalized. And if they are hospitalized, you would want to have intubation equipment nearby. For an infant with bronchiolitis, you want to initiate isolation immediately if they are hospitalized. You can room 2 babies with bronchiolitis together. They will need humidified oxygen to keep their O2 sats greater than 90%. They need hydration. These babies will not be drinking to start with, so they need intravenous fluids, and then as they are able to take more PO in, we can go just to PO fluids. They will need nasal suctioning. Chest PT is ineffective and should not be done. Hypertonic saline nebulizers are the treatment of choice because albuterol nebulizers are ineffective. CPAP may be used for moderate to severe cases, and those children will be in the intensive care unit. And the best treatment is a prophylaxis with intramuscular palivizumab or Synagis immunizations. So this is a bronchiolitis score that can be used, and the score goes from 0 to 1, 2, or 3, and then you would rate respiratory rate, retractions, nasal flaring, wheezing, and general status. So respiratory rate of under 30 is a 0, 30 to 45 is a 1, 45 to 60 is a 2, and greater than 60 is a 3. That means that they are in respiratory distress. For retractions, no retractions or only intercostal retractions would be a 1. Intercostal, subcostal, or supraclavicular would be a 2. And if they have the abdominal seesaw respirations, that's a number 3. For nasal flaring, if there's no nasal flaring, that's a 0. Mild and rare is a 1. Moderately severe and intermittent is a 2, and severe and continuous is a 3. For wheezing, none is a 0. If it's heard only with a stethoscope, it's a 1. If it's heard on expiration with a stethoscope, it's a 2. And if it's heard on expiration without a stethoscope, it's a 3. For their general status, if they are normal, that's a 0. If they are moderately uneasy and with an occasional cry, that's a 1. If they're very uneasy and have a continuous cry, that's a 2. Or if they're lethargic, that is a 3. Acute otitis media follows an upper respiratory infection. They have an earache, fever, and purulent drainage. Diagnosis requires all of the following: that it's a recent abrupt onset, that there's middle ear fluid and a bulging membrane, and that there's signs and symptoms of an ear infection such as a fever. Treatment is watchful waiting for 72 hours. However, watchful waiting is not recommended for children under 2 years who have acute symptoms, and it is also not recommended for all infants under 6 months with acute otitis media. They need antibiotics. If they need surgery, it will be a myringotomy, tympanostomy tubes, and possibly an adenoidectomy. And the tympanostomy usually is for treating recurrent otitis media. Chronic otitis media results in a hearing loss, and children usually have difficulty communicating and may also have tinnitus, so they'll do an adenoidectomy. Otitis media with an effusion, they will get antibiotics only if it lasts more than 3 months, and you need to use a pneumatic otoscope to differentiate AOM from OME. This concludes the review, and thank you very much.